And we're live. Good morning, good afternoon, good evening, whenever or wherever you're watching. This is the Healthcare Leadership Show with Marion Spears Carr. I am your host. Thank you for being there for this special edition of my show on a topic that I've been wanting to talk about for a while now and planning on doing a series of these discussions throughout the summer and throughout this year. Today's topic is Beyond Policy, Rural Health Transformation Realities. And we're going to be talking about the Rural Health Transformation Program and some of the steps that it's going to take for rural health organizations to take advantage of it, but also what are the challenges out there. And the panel that I put together today is incredible. And I'm going to let them introduce themselves. But if you're watching live or watching the replay, please post in the comments. Let us know where you're watching. Let us know where you're watching from and who's in the audience. We thank you for accepting the invitation to this show. And we look forward to the next hour really going deep with the topic and getting these experts from their different points of reference to discuss it. So if you have questions, post those in the comments as well. Let us know where you're watching from, and we'll get started. My name is Marion Spears Carr. For those of you who are watching the show for the very first time, I run a company called Inflow Executives. We are an embedded executive search and leadership development organization based in Georgia, but we work with rural and community hospitals all across the United States. I've been in that work for a very, very long time. I'm from the rural areas of North Carolina and live in the mountains of Georgia. So this is a topic that's not only a professional topic of interest of mine, but it's very personal. A lot of my family and a lot of my stakeholders and people that I serve myself are impacted by what's going on in rural health. And I've watched throughout my 35 years hospitals going out of business, not being able to provide the care and services that those people in those communities deserve. And I'm excited to understand more about how this program is in position to do that. I'm going to let the audience or let the participants introduce themselves briefly around the circle, and we will go. We'll just go in order of how I see them, and they're going to introduce themselves, tell you a little bit about their background. What I recommend, if you're watching the show, connect with every one of these individuals on LinkedIn, and we will go from there. Craig, I'm going to start with you. Craig, I'd like for you to introduce yourself, tell us just a little bit about your company. But here's the question I want everyone on the panel to discuss. Why is this important to you? Craig, introduce yourself, and then love to have you answer that question.
Yeah, my name's Craig Vondran. I'm the Chief Strategy Officer for Rochelle Health. Our core business is we work with a lot of the large health systems and provide on-demand technologists to come service their needs from ultrasound, echo, MRI, CT scanning perspective. It works great in metro areas, but not in rural. So about a year and a half ago, we introduced the ability to do scanning remotely. So we did a couple pilots in Texas and Montana to prove out the concept. And we've been kind of pushing that forward. And now with the rural health transformation, we've been really engaging at the state levels. And it's really important. I live in Kansas, which we have the third most number of critical access hospitals in the country at around 82. So it's very significant just from the state I live in. But just trying to get healthcare to the people that need it in the country, in the rural and frontier communities are very important to our company, since it does amount to about 14% of our population. So that's what we've been focusing on, is getting care to them as well.
Thank you, Craig, and I'm glad to have you on the call. You and I actually met at a rural health conference a few years ago when I was speaking at that conference. So glad to make that connection. Next on the screen is a gentleman I'm getting to know a lot this last year through my connection to University of Georgia and here in the state of Georgia, Tyler Wallace. Tyler, welcome to the show. Thank you for being a guest, and love for you to introduce yourself, talk a little bit about your work, and answer that question around why is this important to you.
Marion, thank you so much for that introduction, and thank you for pulling this group together. My name is Tyler Wallace. I manage a company. We do innovation and AI adoption for community health and rural hospitals, as well as FQHCs. I'm also a faculty member at the University of Georgia, where I teach health informatics, Go Dogs. And why this is important to me is that I'm a big believer in technology as an enabler for change. And so we know that we're about to undergo a lot of change with the Rural Health Transformation Program. So how do we work with folks who might not have all the resources available as some of the larger facilities to get them ready for everything that's about to happen? And so that's my why, Mary, and I'm excited to be here. Thank you.
Glad to have you. Glad to have you, Tyler. And Tyler and I connected through a mutual contact, and we met at a conference, an ACHE conference here in Jasper, Georgia, a couple years ago. I'm glad to have you in my circle, Tyler, and really appreciate the work that you do. HD Cannington is in HD, and I got to know each other via phone just a few weeks ago, and we met through another mutual contact, Kelly Johnson, who connected with me and Tyler. HD, you're here in Georgia, and you are a wealth of knowledge about what's going on in rural health in your state. Give us a brief introduction and why is this important to you? HD, I'm so glad to have you on the call.
Thank you, Marion, and it's good to be on the call. And I'm from South Georgia, and I'm actually down in Tifton right now. Still have family and a lot of friends down here. Live up in Madison, but I've always wanted to be in healthcare and ended up being a lab technologist in the Air Force. It was a God thing. He kept opening doors, and I'd run through them or kind of ease through them or whatever, but started out in the laboratory. And as I was going to college, I went to University of Georgia, Go Dogs, but I ended up finishing up down at Valdosta State and was in accounting and going to be a CPA and all of that. But this ran into somebody there that was a CFO, and he hired me as when I got my degree. He said, if you'll come and work for me for a couple of years as my assistant, then I'll help you get your own hospital. And that happened. And so I became a CFO of a hospital and did that for a while, medium-sized hospital. But then all of a sudden, I decided I wanted to be a CEO. I felt like I could. It's just something I wanted to do. And so, but to do that, I had to go to a small hospital in a community, Graceville, Florida, with 2,700 people in it. And so that's where I kind of got started, and I really found what I feel like is where I needed to be. And I worked in rural hospitals, and it was not so hard until they came out with all the changes. When it was cost reimbursed, it was okay and all that. But I was a finance person, and I'm still a finance person deep down. But I also love rural hospitals. Went overseas a little bit, came back and started doing interims. And I would have friends call me to say, hey, somebody left, somebody just lost a CFO or a CEO. Can you help them out for 3 or 4 months? Sure. It always turned out to be about a year and a half. And what I found out is that the people that work in rural hospitals, like other hospitals, you work in a hospital because you care for people. And it doesn't matter if you're a nurse, a doctor, a maintenance guy, housekeeping, you're there because you want to serve people. And the ones that don't stand out like a sore thumb, and they're out of there. But the thing is that the other thing I found in rural hospitals is I'm coming in from somewhere else, and I'm trying to help them save their hospital, and they own that hospital. And if something happened at the hospital, it didn't affect me because I'll just go back home, but it's their place. And unfortunately, I worked in one hospital down in Southeast Georgia, and it closed. It had filed bankruptcy before I got there. We could bail them out, but couldn't. And it closed. And right now I actually talked to the attorney for the hospital. It's been closed since 2014, and I'm hoping that we can reopen it as a rural emergency hospital with some of the funding for this. So why am I doing this? I've seen what a rural hospital closing does to a small community. I'll tell you that 2 people died within the first 2 weeks. A 4-wheeler accident. They threw them in the back of the pickup truck like they do in South Georgia, rushed them to the hospital. They didn't know the hospital was closed. By the time they got to the next hospital, 35 miles away, didn't make it. And then there was an older gentleman that went to the hospital to have his blood pressure checked because he'd been visiting his wife, and that was the recommendation. He went by the hospital, it was closed, so he drove home and got into a recliner, like most of us would do, and thought he'd be okay, but he wasn't. And when his daughter came and checked on him, again, he passed away before the ambulance could get there. So it's important to me because not everybody, I can go anywhere I want to go, guys. But some people cannot. People that, older people, which I'm old, but I've been blessed. People that don't have the wherewithal monetarily or a car or whatever. And everybody needs health care. So that's why I'm here.
HC, thank you for actually just painting the personal story to this. This is exactly why I wanted to put this thing together. So thank you for doing that and telling that story. We got some people checking in. Erica Harrison Evans is checking in from Althea Health Partners in Watkinsville, Georgia. Go Dogs. Dino is checked in. He's dropped a presentation in the file. I'm not sure what that is, but that's okay. Glad to have you, Dino. Tom Kirkland checking in from Waynesboro, Georgia. Jennifer Juicy is checking in from Chattahoochee Hills, Georgia, and she's rural health access to and quality of care is critical, which you just nailed. Jennifer, thank you for being in the audience, and that is such HD. You just highlighted that. And then and Leslie Kincaid is checking in from Ozark, Missouri. And Leslie is head of physician recruitment, someone I've connected with for years. So glad to have you. Let's keep going around the room. Krista Drubik and I have been connected on LinkedIn. She learned about this discussion when I did a post and offered her expertise. Chris is going to bring a different insight from more national focus. Chris, introduce yourself. Thank you for being on the show and being a part of the discussion.
Thank you for having me. I'm Krista Drobak. I am in Washington, so I do take a more national look at things. I spent some time as the deputy director of the Department of Healthcare and Family Services in Illinois. I also ran the health division for the National Governors Association. I worked on Capitol Hill in the Senate for 5 years and also worked at the Center for Medicare and Medicaid Services. In all of these jobs, rural healthcare was a major challenge and always trying to solve it. So in downstate Illinois to all the work I did in Medicaid at the Governors Association, plenty of tried solutions on Capitol Hill. The thing I like about the Rural Health Transformation Fund is that there is a fair amount of flexibility for innovation. So, when you think about Medicaid, there's a lot of rules. And if you want to do a waiver, it takes a long time. There are very few pots of money that are somewhat fungible where states can just try different things. And this pot of money specifically, you can't use it for services that are already reimbursable. So it really forces people to think outside the box and, how can we really change some of the ways that we're doing things in rural areas to give people more access. So thank you for inviting me to be here.
Well, Chris, we're really glad to have you on the discussion, and I'm glad to connect with you and excited to talk further about the work that you're doing and how you can give some insights. Next up is Corey Lively. Corey and I go way back. Corey is one of my favorite people in the industry, and Corey's a hospital CEO, and he's also the chairman of the board of a group of hospitals out in Oklahoma. Corey, introduce yourself. So glad to have. Thank you and Corey. Thank you, all of you. Thank you for wanting to be on this discussion. But Corey, really truly appreciate having you here. How are you doing today?
Good morning, everybody, and thanks, Marion, for the invitation to share, some of the great things that are happening in Oklahoma and around our state from a rural health perspective. Again, appreciate it. Corey Lively, CEO, Great Plains Regional Medical Center. We're a 70-bed acute care PPS hospital, about equidistant between Oklahoma City and Amarillo. My career early started in the for-profit world, and I had the opportunity after about 10 years to come back home to Western Oklahoma and give back in a different way as a hospital CEO. We're a nonprofit organization, truly a rural independent hospital. And I appreciate HD's comments about not ever really wanting to start out as a hospital executive. I started out as a licensed counselor and helping people along the way, really in geriatrics, and developed that love not only to help people, but then to give back as I moved into the executive role. And so I think the why for us and me personally is to create a sustainable rural healthcare model where you provide access to quality care that's timely and it's appropriate for your community. That's one of the most difficult conversations that we can have. And as a regional referral center, we're home to some of the region's only 24/7 general surgery, orthopedics, urology, OBGYN. We're rapidly approaching an OBGYN desert in Western Oklahoma and part of the Texas Panhandle. And so strategy-wise, it's really important that the model we create is sustainable, not only for our hospital, but through the collaboration with the Rural Health Transformation Program.
Corey, so glad to have you here, and you're the representative of what really is going on at the front lines. And thank you so much for that. By the way, if you're watching the show and you just joined us, please post in the comments and let us know that you're watching. Eric Strauss, Krista, you have a fan, Eric Strauss, that says, "Hi, Krista Drobick." Eric Strauss is checking in. I'm not sure where from, but you have a fan. He's over in the comments. So there you go. Saying
Seriously, I went to high school with Eric Strauss. My goodness,
well, there you go. Well,
Hawkins dance. Wow.
The
Amazing.
healthcare
The
leadership
blast
show
from the
brings people together.
past.
That's awesome. But anyway, I'm going to start. Chris, I'm going to come back to you in a moment for a question, but I really want to start. Corey, I want to start with you. And then I want to go to HD. Help us understand, and I think HD really hit on it in his introduction, but help us understand kind of what the problem is briefly, and then. Oh, wait a minute! I apologize. I didn't miss them on purpose. But this is live. Here you go, live introductions. John Wendling. I didn't take you for granted, John, but you've been a friend of mine for so long. You're just always around. John is one of my channel partners. He and I go way back. John is down in Texas. John, introduce yourself, and then we're going to come back to the questions. My apologies.
No problem. Hey, listen, my name is John Wendling. I'm the managing principal for an agency called 21st Century Healthcare Solution. I've spent 35 plus years in the healthcare setting, kind of as Corey had mentioned, and HD. I actually started off as a scrub tech in the operating room many moons ago at Cincinnati Children's. Yeah. Then as your career moves forward, I ended up working for a large integrated healthcare delivery system, 32 hospitals across 10 markets in 5 states. A lot of those were rural states. I had operational accountability, and at one time was leading 2,700 employed physicians across both urban and rural areas. As some would say, I moved to the dark side in 2006 when I moved over to the managed care side. It was always my perspective to bring a little light to the dark side. My primary focus today is working with organizations, either through legislation, policy reform, placement on the General Service Administration schedule, for both local, state, federal government opportunities, and today working with a lot of these organizations around rural health. Why this is important to me, I'm a Kentucky boy. The Wildcats, by the way. And, you know, I grew up in northern Kentucky. I've got a lot of roots. Estelle County, Harlan, Hazard, Kentucky, which are very old coal mining industry and very depressed in these days. You know, when you look at the state of Kentucky, for example, they have 98 rural and critical access hospitals and 181 rural health centers, with facing a lot of the challenges that we face across the U.S. Closures, workforce, and so to me, this is extremely. It goes deep into my soul and my heart, and trying to help organizations stay successful and be able to treat their communities.
Thank you, John. And I've gotten to know the work that you're doing. We've talked about Kentucky quite a bit, and some of the other states you're making a difference in. So thank you so much for being on the show. Corey, I'm going to come to you. It's like, give us just a brief, for those who are watching the show that may not be familiar with what's going on in rural health, and I suspect our audience is particularly interested in healthcare rural. Hold on one second there. That there might be an awareness of going on. But Corey, can you just give us a little insight on what's the challenges right now in the rural health, and why is this program going to be or is important? And then we're going to talk about solutions. Krista, after that question, I want to talk about the fact that this is a state-by-state RFP process, and I'd love for you to kind of give some insights around that, and then we'll go around and get some of the other people on and ask their questions. Andy's checking in, by the way, from Oklahoma. Kelly is checking in from University of Georgia. Corey, can you give us a little bit of insight, and then I'm going to go to HD on kind of what the lay of the land is in terms of the challenges, and then we'll keep this story going.
Appreciate that, Mary. And, you know, there's significant challenges that rural hospitals face. And I think primarily for us in looking regionally, it's workforce development, workforce availability. That includes all staff, all physicians, you know, hearing the clinical background of individuals, whether it's counselors or surgical scrub techs. Everyone is scarce and everyone is in demand. And we as an organization have developed those programs with our regional universities to solve that. But it's not just one problem. It's not two, it's not three. It seems like every portion of our clinical delivery and our business efficiency is being attacked right now. And that's not only local, but that's at our state and our federal levels as well. Advocacy that you'll hear hopefully later in this conversation is so incredibly important. I know the American Hospital Association meeting is this week in Washington, and it was not able to be there because I chose this, Marion. But the reality,
Thank you.
It's every forefront that we face, and the challenges continue to grow, and there is a critical mass. Not only of people, but of finance as well. And if you don't meet those challenges, or you don't collaborate or find ways to think outside the box, I think, as Krista mentioned, in unique and creative ways to utilize transformation dollars, not on operations, but to strategize and to create strategic pathways to create success.
Thank you for sharing that. And that's the common thread of the conversation that I've had in the states that I work in a lot. Craig mentioned Kansas. That's one of my areas of focus. Texas, Oklahoma, where you are. Obviously, the Carolinas, where I'm from. Here in Georgia as well. HD, I would love for you to briefly, and I'm going to unmute you. I had to mute you there for a second. Tell us, what's the specific thing you're working on right now? You talked about trying to get this hospital open, and you humanized the whole thing with those two stories, and I love that you brought that up early. But what's one of the things that one of the problems that you're trying to address right now through the RHTP program here in our state?
Well, I've been in touch with these people, and I'm trying to think of how to frame this. I'm working on another initiative with actually a physician called me. Dr. Wayne Myers had called me back a few months ago, and if any of you know who Wayne Myers is, he established the WWAMI Project. He ran the back in the 80s, and he ran the Office of Rural Health Policy for a couple of years. But he called and wanted to set up an APGAR score for rural hospitals because there's so many closing. And of course, the thing is, after we talked on the phone, there were like four of us. We always talk about the financials, because that's, rural hospitals struggle financially, and it's just a part of it, and we can dig into that. And of course, I had to remember that's my background, that's what I do, and it's very important to me. But it's more like it's a symptom. It's not the problem. The problem, we looked at the drive-by phenomenon because, local residents think sometimes that bigger is better. But what we finally figured out is we as rural hospitals oftentimes don't educate our community. I've been in hospitals where the doggone, even the employees are not educated. They're told to do their jobs. And the thing is, it's kind of like Corey talked about, when you're in a rural hospital, especially as whether you're a clinical person or what you are, you're there and you're trying to do the best job you can, but you need leadership and talk about being nice to people and letting them know when they're waiting in the ER for 3 hours. Don't just walk by and look the other way. Go in and tell them, say, hey, we just had an ambulance came in, an ambulance came in, and it's got 2 people. We're trying to say, well, we're going to get to you in just a few minutes, and things like that, but treating people nice. But the other thing is, I've been in communities where the people in the community, and this is their hospital, and they don't know that there are any problems in the hospital until they find out it's fixing to close, or it's going to be taken over by a bigger hospital or something. And that's one of the things we're working on, is presenting more transparency, and also a part of the RHT grant. This whole thing, I really like the fact that it talked about collaborating. And guys, you have to remember, I am rural hospital. Now, I've dealt with a lot of other healthcare providers, but I know in 1993, the state of Florida came out with a $75,000 grant to develop networks. And I was a part of a 5-county network, but the grant required that you have the local health department as a member of this group, and any FQHCs, community health clinics, and the thing is, is that I had never sat down at a table with the public health director. I'm hospital. Why do I need to talk to these people? It was interesting when I found out, and I'm getting chill bumps talking about this, because it was interesting to find out that they're interested and they're trying to fix the same things I am and the same things we are, and getting those people. And you mentioned FQHC, Corey, and I worked a lot with rural health clinics, under CAHs and stuff, but never with FQHCs until about 3 or 4 years ago. I got to go and be the CFO of one for a few months. But the thing is, we got to work together. And these are other community. We have to find where we're all trying to help save healthcare in the rural communities. And through collaboration, it's huge. And then you start bringing in not just your top community leaders, but also city commissioners, county commissioners. This impacts them too. Get them on board. Yep. And the other thing we come up through this APGAR group is, we don't tell the stories. We just don't, people in, rural communities, they talk a lot. And so when
Yeah.
somebody goes to the ER because they fell and hurt their shoulder and it's not a life-threatening emergency, so they sit in the ER for 3 hours, they're going to tell all their friends about it. But whenever you can do a testimonial, and most rural newspapers are dying, they'll print anything. And I actually worked in a hospital where we had a really, 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 really good, PR person, marketing person, whatever you want to call it. But she was from the community. And so she came up with this idea of talking to patients and getting a picture of a patient that says, I went to Morgan Memorial Medical Center and I fell, and they went in and set my arm or did this or did that. And then when I went to my doctor in the big city in Athens, he said, if you had not gone and they had not done this at the local hospital, you may have lost your arm. Now, guys, that's huge. And when it's a local person that's known in the community and they will do that, all of a sudden people start thinking, I think I'm going to go by the ER there and I'm going to check it out and I'm going to do this. So I think that we have to look at financials, and you really don't want me to start talking about Medicare Advantage. Bad. From a hospital standpoint,
we will do that on another show. HD.
Another show. I'm going to stop.
We will do that on another show. Another show. Thank you, but I love your passion, HD. Krista, I wanted to come to you, and then I want to get to John, and I'm not leaving Tyler and Craig out. I knew it was going to be a lot of people in the conversation, but Krista, talk about the fact that each state is doing. Obviously, there's this $50 billion fund that's going to be over the several years each year, but each state is responsible for establishing their RFP, a request for proposal process, on all the different tiers. Could you just give us a little bit of insight on what some of the states are doing, and how you're involved with that? And then that would be really helpful to kind of set the table on what each state or what some of the states are doing. And then I want to come to you, John. I got a question after that.
Well, let me first tell you that I tried to put this in the chat, but it didn't work. The Health Policy Futures Lab has webinars and convenings, and we're just about to release our first playbook, and you can see the states talking for themselves. All of our webinars have state officials, and we're going to have a convening of state officials in June in Washington. And the paper that we're releasing is going to be the first week of May, and it's on clinically integrated networks, like what Corey is participating in Oklahoma. Clinically integrated networks truly are a really effective way for rural hospitals to not only just stay afloat, but provide really good quality care. States you can see most of the applications that states submitted to CMS, and there weren't a lot of really dramatic differences between the applications and what we're actually seeing for the RFPs that are coming out. CMS is not basing this not measuring states on how many RFPs they put out or how much activity they have. It really is based on performance. And states have to report to CMS on a quarterly basis and on an annual basis on the success that they're having with RHTP. The reason I tell you this is because this is happening fast. Everything is coming out, and now there is a deluge of RFPs coming out. So even just a simple Google, like a flag on Google can allow you to see what's coming out if in the states that you're particularly interested in. We're seeing a lot on managing chronic disease, using technology to manage chronic disease. We're like, for example, remote patient monitoring or telehealth. We're seeing things on improving electronic health records. So can we invest in EHRs so that hospitals can talk to each other better. We are seeing mobile health clinics. Very interesting. This is something that is not reimbursable for the most part in Medicare and Medicaid. So it really is fertile ground for states to invest in mobile clinics. And those are anything from screening for, cancer screenings, for example, all the way to training rural providers on obstetrics. So like there's a rolling training facility. Also doing actual procedures in mobile units. So it really does span the gamut. And then the last one I'll say that's really interesting is EMS. So using EMS in different ways, community paramedicine, for example, but partnering with EMS services as workforce extenders, pharmacies the same way. How can we use pharmacies in a different way? So there is a lot out there, and states are learning from each other. So we are very dedicated to having states learning from each other and bringing states together, because nobody needs to be out there alone trying to figure this out.
And Kristen, glad to have you on the call to give us that perspective, because I was at a conference. I just spoke at the Texas Hospital Insurance Exchange Conference in Abilene a few weeks ago. And one of the conversations was around how EMS is being supported, grown, expanded, particularly the quality of skill sets that they have to support. So that is in line with what I heard about at that conference. So thank you. John, I want to come to you, and then Craig and Tyler, I'm not forgetting you, brother. So I got you. John, talk about with this process of the RFP process, what's happening? Is there things happening legislatively or happening in the states that you're working in that are very specific to creating the platform to really take advantage of the fund? What are some of the things that are going on that you're aware of? I think you're muted, John.
I apologize. Usually don't hear me being silent. Anyway, yeah, from a legislative perspective, I can tell you, in states like Kentucky, Ohio, Texas, Nebraska, this is at the forefront. Most of these initiatives are going to be generated through the state cabinets or the state health and human service departments. And where I want to actually take this is what provider organizations, for example, need to do to engage and participate in these federal dollars. And I'll just give you a few statistics real quick. Texas was awarded $281 million. That's the highest. Alaska came in second at $272 million, and California and Montana came in at just under $234 million annually. So here's kind of the roadmap for provider organizations. Initiate those relationships early with the state agencies. And don't be concerned if you haven't started those engagements. This is a 5-year program, and these states submitted to CMS their framework for how do they want to address this. So this is still very early in the process as far as how they're going to actually roll this out in a lot of situations. It's very important to conduct an internal readiness assessment in your preparation to be able to participate in the Rural Health Transformation Program. Engaging with community stakeholders, critical to meet with patients, local government, EMS, behavioral health providers, and social service organizations. Develop your initial primary financial and operational models, align with regional and multi-provider collaboratives, prepare data and evidence, support your case. And then you need to have a clear pathway as far as your governance and leadership commitment to this process. It's a lift. And all of this will eventually lead up to your narrative. And that is what you will present to your state in a concept paper And then there's some other pieces that you'll want to share as well. Another thing I would highly recommend, and what we've heard from legislators, is strategic partnerships, whether that be through provider organizations, but also some of those technology solutions. An organization like We Connect Health, for example, who has a digital mobile app platform that provides 24/7 peer support. And I'm not advertising for this organization, by the way. But what this does is it also addresses gaps in care. Especially when you look at rural USA, we don't have the infrastructure, we don't have the resources to have necessarily boots on the ground all the time, and so these are critical. I'll just throw in one more piece of information. It's not a requirement, but for organizations that outside of the provider organizations, social service organizations, it's not, like I said, it's not a requirement, but those entities where you would align strategic partnerships, it's helpful if they're on the General Service Administration schedule. And this is just a process process go through. They've already vetted, they already have the pricing models, and it's a quick process from a need to for a state, local, federal, or even through tribal government to be able to quickly move these through the process.
Thank you for continuing while I dropped out. We had a little internet issue, but you guys kept going. You're still in there, so that's awesome. And by the way, if you're watching live, let us know in the comments. We do have some questions coming up. We have a couple of things going on in the private question. Thank you, Tyler, for offering to facilitate. So I'm going to come to you, John. Thank you for sharing all that information, because and I was able to watch it, but I just couldn't hear it on my end. Mm-hmm. Tyler, so he's talked about all the different opportunities out there and all the different states, what they're doing. From your perspective, what are some of the things that hospitals are doing right now to prepare to take advantage of all this? And maybe y'all talked a little bit about that. I may have missed it. I love the shows live and I got good people on the show when I'm not there. So thank you. Anyway, Tyler, the question is to you is like, how are they preparing?
Yeah, that's a great question. I can't speak to all preparations. I can mainly speak to technology and innovation and all of that. I think it's been great because Corey has talked a lot about workforce development, and Krista said this is all moving really fast in technology, and John has brought up tech as well. And so what I'm seeing are rural hospitals and FQHCs even investing in their staff to get them ready for all of these changes. So we know that this administration is big on AI and agents, and a lot of talk in the press with, the AI avatars for mental health, and then using AI on the prior auth side for piloting for those types of traditional Medicare, right? So we know AI is starting to be big with this administration. And so we see that, and then we see that almost every tool coming forth is going to have some sort of technology or AI or innovation. So we are starting to see organizations invest in their staff to say, hey, we need some skills on innovation. We need, tech skills. We need AI skills. We need to really invest in those. And so that has been fun to watch, especially as an educator, to see people try to upskill their staff. We see CEOs, CIOs say, who's going to own this training their people going forward, and especially with CIOs. This typically hasn't been in the CIO's wheelhouse. But with AI, and everyone is using artificial intelligence at home, we got 80 to 90% of Americans use some sort of ChatGPT or Copilot or Claude on a weekly basis. And so we're seeing that kind of permeate into these healthcare organizations. And now you've got people bringing their own personal AIs into these hospitals and healthcare systems. And so how do you get ahead of that? And so really putting the tools in place, but then educating staff on how to use these tools the right way. and providing AI tools, because if the organization doesn't provide AI tools, people are going to bring them from home. And so rolling out, even just getting started. So teaching people how to use things like Microsoft Copilot, and here's how AI works. Here's what a large language model does. Watch out for hallucinations. All of those are issues that we're going to see going forward with AI and innovation. And so seeing organizations get ahead of that has been fun to watch on my end. So thanks, Marion.
And you've been posting a lot on LinkedIn. I've been learning from you as well. So thank you for that. And thank you for that. And so carrying on from a technology perspective, and there was a comment in the comments that said that all the tech in the world will not work without staff. I think everybody on this panel is aware that workforce development is a critical piece of this. But when there's technology that can supplement, can support, and drive operational efficiencies, improve patient care delivery, we need to talk about that. It's not just, I think that's one of the challenges, and I probably need to do a show on one of the challenges around, if everybody thinks that tech solutions are the only solutions available and that's where we're all going to spend all of our money and focus on, and not worry about the workforce piece, they're not separate discussions. They're discussions. We need a workforce that's trained, as your point, Tyler, to use this technology and to leverage the technology. Just to your point, they're going to bring the technology. They're going to bring ChatGPT or whatever version of AI to work anyway, right? So I think there's a bigger picture here. I think people are so siloed in talking about this particular solution. I think it's a much bigger picture. So I just want to point that out there. Craig, I do want to talk about, love for you to talk about kind of from a tech perspective, what are you guys doing? And you're also on the staffing side as well. So Craig, give us a little insight about the kind of solutions that you're providing. And then there's some great questions going on in the audience, and I want to bring those up as well. What a great discussion. And I know this was going to be one that would be very robust. So Craig, your thoughts.
Yeah, kind of picking up for what Corey and Krista were saying about some of the needs out there. From our company's perspective, we looked at everything that was happening and the initiatives being released, and we put together a turnkey solution and had some strategic partners to try to solve some of these issues. And what I can do is go through the top 5 initiatives that have been put out there based on the state's submissions for funding. And the first one was already mentioned earlier, workforce development is a huge problem. So recruiting, training, and retaining people. So the solution we threw out there was actually going to be upskilling current staff by teaching them to be what we call operators. So when you're doing remote scanning, you can have individuals on site that aren't skilled at that. It could be a CNA, an MA, a nurse, it doesn't matter. They don't have to have experience. We would train them to be able to capture images under the guidance of a certified sonographer that's doing this remotely. And we've proven this out in Montana and Texas, and are actually helping create a pool of new skilled workers in Montana. We've partnered with a community college out there, Miles Community College, and recently did some training for their 15 soon-to-be graduate nursing students, and kind of train them on that process so they could go into their new rural facilities and provide that. So we're kind of pushing a grow your own process that can be duplicated in any state. The number 2 initiative listed out there is sustainable access to care. So primary, emergency, and maternal care. This was a big one for us because roughly 14% of the population live in rural areas, and 39% of those patients have access to ultrasound and echocardiography compared to 90% in urban regions. So the solution, again, will provide access to all patients regardless of where they're at. We're really big on your zip code shouldn't determine the type of care you receive. The third initiative, technology and data modernization. So adopting telehealth, doing remote patient monitoring. And again, that's one of the reasons we partnered with GE Healthcare in this turnkey proposal, because they would provide some new equipment that's AI enabled that actually assists with probe placement and actual image capturing. So when you combine that with a certified remote technologist, it's a perfect solution from that perspective to bring that service to these facilities. Another one is the preventative services in chronic disease management, reducing chronic diseases and addressing the root causes. Everybody knows that the proper treatment or management of chronic heart, kidney, and liver disease requires imaging to diagnose, monitor, and determine if the treatment plans are working. So again, that addresses that issue. And the last initiative that was out there in the top 5 is creating regional hubs and rural networks to connect with the larger networks. So again, providing the solution at the regional locations will reduce some of the travel and provide a greater reach to these other facilities versus what's currently in place.
Yeah, I love the fact that you just kind of lay that out and all the different components there. And so thank you for sharing that, Craig. There's a great question in the chat. I'm going to bring it up, but Corey, I'd like to start with you because and I think it speaks to something that HD talked about, is about educating the community, like educating the actual patients. And the question is, I'm going to ask this in a much broader question, but Johanna, I really like this question is, how are we making sure patients and rural residents will use technology? We're talking about technology solutions. These solutions are not sustainable if they're not adopted. I want to get that question answered, but Corey, on a broader perspective, you not only are the CEO of one of the largest rural hospitals in independent rural hospitals in Oklahoma, but you're also part of that clinically integrated network that Krista referred to and you've referred to.
Right.
What's something you guys and your group are doing to educate the community, not only about their technology opportunities, but how to take advantage, I guess on a broader scale? How are you focused on educating the people in rural Oklahoma on how to take advantage of the services available? Because a lot of the stuff, HD pointed out that 2 people went to a hospital, didn't even know it was closed.
Sure.
So big question there, Corey. I hope that made sense, but I think it speaks somewhat to Johanna's question, but a much bigger scale. We got to get the patients in the community involved. So your thoughts?
So as the CEO of our organization, I think we have to be the foremost champion of not only our hospital, but our people, our services, our physicians, and we have to shout that from the mountaintop, even from the Georgia mountaintop, Marion. And so I think when you do that, and I listen to all of the difficulties and the organizations that we face, it's a daunting task. And we've been very fortunate to be a part of Life Care Health Services, which is 9 independent hospital members representing 18 hospitals. Coincidentally, we're the largest statewide rural provider network in Oklahoma. And our ACO, we're up around 80,000 lives. And we've had a very robust operating process for many years. And so as we engage and go forward with these dollars, we're creating community health workers that are connectors. And what they do is connect additional services from our communities to our hospitals, to our regional life care partners. And so it's just a pure focus on developing a program that really truly is not only a connector of patients, but a connector of our life care hospitals and the additional hospitals in our region, so that they also know what we provide, whether it's 24/7 orthopedics or cancer care or things we're offering regionally as our partners. And so as we use these dollars to embed new and additional ways to educate our community on everything that we offer, from workforce to services, that's the way that we're choosing to kind of engage from a technology perspective. They're going to carry all the electronic tools necessary to make those things happen right at the point of sale, if you will, so that if they're in a physician's office in a town 30 miles away from our regional organization, they can connect us directly right there. And so that's a cool part of what we're seeing in this process.
Thank you for sharing that. We've talked about that. You and I have talked about that, about the fact that that's how we go about changing care. And Dino's making a good comment in the chat about teaching the family to be the first responders, helping them understand how the monitoring equipment works.
Well, the other thing,
to telehealth and how that works.
Yeah, sorry, Marianne.
Yeah, John.
The other thing,
I was coming to you.
Oh, were you okay? Hey, you know, did you have a specific question, or
No, I thought you'd have a point on this. So that's
all right. No. So I was going to say one of the critical pieces of this is you have to meet the people where they are. You have to, not where it would be ideal for them to be, where they would be. We have significant challenges across the U.S. In urban areas, but specifically in rural areas. There's just these huge gaps in care. And, I think it's critical. If you want, whatever the solution is, you have to be able to build trust. And so, I think it's important to engage with who the rural residents often trust: local clinics, community health workers, peer recovery coaches, faith-based organizations, county health departments. It takes a village to solve a problem, and I am a firm believer that it will take the larger effort of a community to help solve for X.
Marion, can I add something here?
Yeah, Kristen. Yeah, absolutely. I was coming to you. Thank you.
We can use other people so much at a higher level than you can train pharmacists, doulas, community health workers are a great example. More and more states are passing legislation on, what a community health worker is and what they can do. They are, these are folks of the community that know the patients, that can really help convey the messages on what's available and sometimes the technology. So really there's a whole web of people that we can include more in the healthcare system.
And thank you for that input, because I think that's HD's point, and as well as is getting the community involved, and the fact that there is some change in the way states see and the nationally sees how we can scale our care delivery by changing some of those things. The doulas, for example, I love that, and those different. It's around. You're talking about takes a village, John. That is the people right there, in the community. We're allowing them to do that. I knew that this was going to run, and we were not going to get questions for everybody on every question, but we have about 3 minutes, and I want to start with Craig and just go around the room to wrap up. Thank you all for watching the Healthcare Leadership Show with Marion Spears-Carr. This is going to be a series of shows on this topic, but I wanted to start with the very large panel, because these are people that are so knowledgeable about what's going on both locally, regionally, and nationally in a lot of different segments. Watch for posts from me and from Inflow Executives, my company, on what the series is going to be about. We're going to talk about different states. We've got a guest coming on talking about what's going on in Indian Health Services. So a lot different going on. So Craig, I'm just going to start with you. One last comment on the Rural Health Transformation Program. And then let's go rapid fire. You, Tyler, about the work you're doing, HD, Krista, Corey, and John.
Yeah, I appreciate that. I think that it's actually a major undertaking for the states to handle, and you see a lot of them actually working with third parties to help them out to allocate the funds. Unfortunately, with the restrictions and the reporting requirements, I think that they should pump the brakes a little bit and give them the opportunity to breathe and roll this out in a proper way, because I think we have a great opportunity to do great things, but they're being forced to do things quickly, and I think that could actually limit the success of the program in the long run.
Thank you, Craig, and thanks for being on the show. Tyler.
Thank you.
Sure. I appreciate that, Craig, as well. So there's a lot of change happening all at once, and we really want to make sure to have our staff prepared. A lot of tools can be used in a really good way. So AI is going to be very helpful and very with clinical, operational, administrative improvements. But also there's a lot of dangers and risks that come along with that technology as well. So I'm a huge advocate for making sure that we are ready just to manage all of the change coming, and we implement AI and innovation in a safe, reliable manner.
Thank you, Tyler. HD, one last comment from you, man, and thank you so much for being on the show.
Well, thank you very much, and I've learned a lot. I'm going to tell you, this has been really good, guys. I've just got some things I'm just going to throw out. You know, and Craig, what you said about pumping the brakes, I get it. And when I first looked at this grant, I'm like, it looked like somebody had thrown it up against the wall to see what stuck. But I actually, a few days ago, looked at something that I think CMS had come out with, and it looks like things are beginning to solidify. There are things out there that are actually, I think, that we can do in rural communities that will help us. I also look back at something, the old ACOs that came, and I'm not sure where they are, but it really is a good way to do it, you know, where care is coordinated and things like that. So I hopefully we'll pick that up. But I hope this grant opens the avenue for people to start thinking outside the box and seeing what they can do locally. And so much of it, I think, is going to be education, whether it's with IT and how we utilize that, or getting these like EMS and pharmacists and get them to get outside the box. But that's going to be the key. And I think that the individuals will come up, individual states, individual communities will figure it out. But one of the things that I've worked, I've never worked for one, but I've worked with them. A lot of these rural health research centers, and they provide a lot of technical assistance. And one of the problems with rural hospitals, having worked in one, is when we wanted to go out and start a new initiative or get a big grant, we had to get somebody to administer it. It seemed like about half of the money was going out the door for that. But I think that there are some things through the Federal Office of Rural Health Policy. I think if we can get them on board, and I've talked to Tom Morris about this, and let them come out with some grants to provide technical assistance to people that are willing to look at things a different way. And I'm going to stop there.
Thank you.
And thank you to all of you.
Looking forward to having you back on the show. Krista, final comments. And thank you. And Krista, thank you for being on the show and bringing your perspective. And I love the fact that the cat just walked behind you. That's awesome. That's awesome. That's awesome.
He has a mind of his own.
So it's real. Yeah. So it's real.
So just check out the healthpolicyfutureslab.org website. We've got a lot of webinars, convenings. As I mentioned, we're doing a paper. If you can't make it to Washington on June 9th, we're going to be recording our live event and we'll put it online. But we're trying to share information across states as much as possible and share information with stakeholders. We're really keeping our finger on the pulse of RHCP. So you're also welcome to write questions to us. So anyway, I think we'll try to keep up the information flow as much as possible. Thanks, Marianne.
Oh, you're welcome. And thank you for Krista being on the show. And I truly appreciated your input. Corey.
As an executive and a leader and an operator of a hospital day in and day out, I think one of the things that has really come to light for us as an organization and all of our other 8 partners in our Life Care Association is choosing a partner that you can trust. And we're very fortunate to have had a long-standing relationship and a company that shares services and creates accreditation opportunities and negotiating opportunities and all these things that it takes to survive beyond just one small rural hospital. Mm-hmm. And so we had 30 years of trust built into that relationship. And as this process is rolled out, that has become incredibly important to us. And I think other organizations, even larger metropolitan organizations, see us as that trusted rural health partner. But what's most important is there are a lot of hospitals smaller than us. And we've talked about hospital closure. There's 2 hospitals adjacent to us that have closed in the last 5 years. And those hospitals could have survived had we had the ability to engage them differently and the funding to do so. And there's an independent spirit sometimes that creates a blind spot. And so I think as we go forward, finding that partner and that relationship that you can trust and providing those appropriate services and utilizing the transformation dollars to create sustainable rural healthcare is what's going to be so important.
I can't agree with you more, Corey. Thank you so much, and glad to have you on the show. Thank you for being a part of it.
Thanks, Mary.
John, I'm gonna let you tie a bow on this, and I
All right.
really appreciate you being a partner in this discussion.
Absolutely. So, from a state capital perspective, I think we should not underscore engagement with both the executive and the legislative branch. When you look at whether through the cabinet or the Department of Health and Human Service within these states, that's an interesting dynamic. And legislators, elected officials are committed to helping to solve for X. And if you've got a good enough solution, you've developed a relationship with Health and Human Service, it can go a long way for meeting the needs of the community and your engagement with this whole rural health transformation program.
Thank you, John. On behalf of the panel, we thank you everyone in the audience. Thank you for all the comments and the discussions. If you want to hear more on this topic, please send me a DM. Let me know what particular areas around the RHTP that is so important to you, and we'll get guests on to have that conversation. Thank you all. This is Marion Spears Carr. This is the Healthcare Leadership Show. Glad to have you in the audience if you're watching the replay. And thank you for being with us. Have a great day.
Thank you.
Thank you all.
Thank you.